Welcome back, students. Today we are going to see about fabrication or complexities in the planning of single complete dentures. So single complete dentures can be either single maxillary dentures which have different challenges or single mandibular dentures which have different challenges. When we talk about single dentures, the clinical problem comes in the difficulty in the fabrication of the dentures. Most commonly, this difficulty is related to the forces which act on the denture, which cause displacement or fracture of the dentures or even induce severe bone resorption because of the unfavorable forces which act on the denture. This bone resorption in turn can also lead to a lot of pathological conditions on soft tissues, on hard tissues. So usually single dentures are fabricated in the maxilla or the mandible, and both of them have different type of challenges. The most common problem with the single denture is tooth malposition. Because one arch has lost dentition completely, there may be a change in the occlusion plane in the remaining dentition, that is the opposite arch. So this causes a tipping or extrusion of the teeth or rotation of teeth, thereby making the occlusal plane unstable. And this also causes very difficult balancing of the dentures. So the common malocclusion is like supraeruption of one or two teeth, which causes a change or a tilt in the occlusal plane. The next common problem is the tipping of the teeth, where one tooth is lost and mesial or distal tipping of the remaining teeth can affect the existing space. And this also poses a problem for replacement of these missing teeth because of limited space. The other problem is placement of denture against natural teeth. See, one arch is going to have natural tooth, while the other arch is going to have artificial dentition. So this can cause a rapid wear of the artificial dentition because that is made of acrylic teeth. And when this acrylic teeth is rubbing against the natural dentition, it can cause rapid erosion or wearing of the teeth or even breakage of the denture. So this will result in more frequent recalls of the patient and frequent occlusal adjustments to prevent stress distribution. So what are the methods for correcting occlusal disturbances? So this is the first step we have to do before starting the fabrication of complete denture. So the occlusal modifications, almost some kind of occlusal modifications is always required to improve the occlusion and stability of the denture. So these techniques describe how the teeth can be modified prior to the denture fabrication. See, occlusal fabric or modification can be done by one of the following methods. The first method is described by Swenson. Here, the maxillary and mandibular cast are mounted on the articulator in centric relation, and the denture teeth are set. The opposing natural teeth which can interfere are ground on the area and which are marked by the pencil. The natural teeth are modified using the cast as a guide. After completion of this modification, a new cast is made and mounted. So here the interfering cusps or the tips are modified on the cast, and then the same modification is completed on the patient and a new cast can be fabricated. If more adjustments are needed, this procedure is again repeated. So the disadvantage of this technique is that it is simple, but it can be more time consuming because several impressions have to be made in case the procedure is incomplete or it is deficient. The second method is called described by Uruktas. So here Uruktas used a U-shaped occlusal template which was slightly convex on the lower surface. So when this template is placed on the occlusal surface of the teeth, the high cusps can be easily identified because this is a convex surface, and this high cusp will be interfering on this template, or it will interfering with the seating of this template, and then they can be directly marked inside the patient or on the cast, and then they can be trimmed on the patient's mouth. So this removes the possibility, or this eliminates the need for multiple impressions, because we already have a occlusal template which can be used for correction. The third method which is used for occlusal correction is the bruises method. So it is quite similar to other techniques, but after marking all the necessary reductions on the cast, that is, you mount the cast and then you make the occlusal changes wherever you want. You are going to mark it on the cast, and then you make a template. Usually the template is made of acrylic. The template picture is shown here, and these template can be seated back into the patient's mouth, and these areas can be trimmed off in the patient's mouth. So the last method is the Boucher's method, where porcelain teeth are set on programmed articulation to achieve the best possible balance. So the interferences are removed by rubbing the maxillary porcelain teeth over the mandibular stone occlusal surfaces. So here we use a porcelain teeth on the maxilla, or if we otherwise if it is a mandibular teeth which is being replaced, then you can use the porcelain teeth on the mandible, and the natural teeth on the maxilla gets eroded in the same manner. The stone casts are then used as a guide to modify the natural teeth until a harmonious balance occlusion is achieved. So one of the most common problems with your single complete denture is the occurrence of this syndrome called as combination syndrome. So this question can come as a short note, very frequently repeated. This syndrome, the other name for this syndrome is also called as Kelly's syndrome. So this is a problem which occurs when we replace maxillary teeth opposing to a mandibular removable partial denture, which means there is a upper complete denture, or we are going to replace the full upper set of dentition, and in the lower we have only the mandibular anteriors which are remaining, and the mandibular posteriors are missing. So what is the challenge faced in this situation? Because the mandibular teeth are anterior teeth are natural dentition, these teeth are more prone to forces, or for example, they can create more forces on the upper denture. Since the upper denture is supported only by tissues in the anterior on the limited amount of bone, the anterior segment of the upper denture undergoes more resorption compared to the posterior. Similarly, because the anterior in the lower they have natural teeth in place, whereas the posteriors in the mandible, they do not have any teeth. So the resorption rate in the posterior mandible is greater. So this causes a downward growth of the posterior edentulous space in combination with the upward resorption of the maxillary anteriors. So this poses a significant challenge, and the patient can also get a lot of soft tissue defects or soft tissue pathologies like this shown in this picture. So this is called as Epulis fissuratum, and is a very common symptom of combination syndrome. So this occurs in a sequence, and the first sequence is excessive load on the anterior region of the complete denture. So this causes resorption of the ridge in the maxillary anterior along with Epulis fissuratum. So this is the initial sign of this problem. So this causes downward movement of the posterior plane of occlusion, producing excessive resorption of the mandibular posterior teeth also. So the downward tilting of the occlusal plane in the posterior region produces an anterior open bite, which leads to supraeruption of the lower anterior, which further accelerates the problem. The sequence 2, the ridge resorption in the mandibular edentulous area proceeds. This causes more downward movement of the posterior part of the maxillary denture and formation of a flabby tissue. There is further supraeruption of the lower anteriors and increased load in the anterior maxillary region of the complete denture. This causes further resorption in the anterior portion and further acceleration of the problem. So the entire occlusal plane is tilted. With so many challenges in single complete dentures, especially combination syndrome, how are we going to manage these challenges? The first thing is to discontinue the use of existing dentures because it is further going to accelerate the problem of combination syndrome. So after discontinuing, you can either reline the dentures so that you allow some time for healing for the defects, or you can modify the occlusion where you can try to balance or remove the improper contacts. Severe cases may be treated by surgical removal of the soft tissue defects like the epilis and refabrication of the denture. We can also remove the flabby tissues in the maxillary anterior region. The next method is to improve the height of the ridge by doing a vestibuloplasty, which is again a surgical procedure. If these things are not working out, then we can consider switching over to overdenture, where the lower teeth are reduced, they are endodontically treated, and the lower teeth can be the lower denture can be changed into a overdenture. So the other alternative is to change both the upper and the lower dentures, whereby we remove or extract the remaining lower anterior teeth in this single complete denture and then switch over to a conventional complete denture in both upper and the lower. The last option is to fabricate implant prosthesis, whereby you can go for replacement of only the missing teeth, or you can just remove the existing teeth completely and go for implant supported dentures in both the arches. With this, we come to the end of this session. Hope this session was useful to you. Thank you.